to talk to VCAT and the people who are on either Zoom or on Instagram or on any other social platform. This is a part of the awareness and question that we have regarding breast cancer. Breast cancer. We do it every year in every October, but I think there is a lot which still needs to be done because there are so many things that are happening and they are changing every time. So, we think it, even if one or two people benefit from it and can spread the message, it would be really great. So, Doctor, first thing that I wanted to ask you was that we will start, the awareness part of it. That how do you think awareness has to be done? And I think we are not really talking about, awareness in terms of cost. Because if in stage one, I believe if you can catch the cancer, the treatment cost would be much less and would go up much higher in stage four with negative results probably. So, do you bring this into focus? Do you think we should talk a little more about this thing, Doctor?
Yes, I think cost implications for breast cancer treatment, or for that matter, any cancer treatment, not just breast cancer, will depend on a couple of things. Out of these, the most important is obviously when we talk about the subtype of the cancer. There are cancers which require, like in breast cancer, there are three main subtypes. We're talking about hormone positive breast cancer, or HER2 amplified cancers, or triple negative breast cancer. And depending on which of these subtypes the patient has, the cost of treatment changes. The other thing that the treatment depends on, or the cost of treatment depends on, is the stage. So like you correctly pointed out, if it is stage one, we are talking about treatment which is of shorter duration. If it is if it's hormone receptor positive, the drugs available are extremely affordable, and people are able to take these drugs for long periods of time without having any financial burden on them. Vis-a-vis, if the same patient had HER2 positive disease, where targeted therapies are involved, which are currently quite expensive. Some of them were expensive about 10 years back, but now those companies don't have patents, and biosimilars or generic medicines are available, where the cost has considerably come down, but the newer molecules are always more expensive. But we also have to understand, when it is stage one, we're talking about a treatment which is going to last for maximum 1 year. And after that, it is only maintenance phase. But when we are talking about stage four, we are talking about repeated testings. We're talking about cost of repeated diagnosis. We're talking about cost of repeated treatments which are offered. And every time a treatment fails, the next treatment, most of the times, is more expensive than the previous one, because you're trying to include a newer molecule, you're trying to include a newer therapy available. And once all this is done, obviously that all that comes at a cost, which has to be ultimately borne by the patient. So earlier we catch it, cheaper it is going to be, and obviously the outcome is going to be much better. Now, in a stage four cancer, when I'm talking about a HER2 positive stage four cancer, the initial treatment that we start, which is targeted therapy, without naming any names, the surgery can, drug which is the targeted therapy which is offered can be anywhere between 7,000 to 50,000. And this is only a single injection, and this injection is going to go on for good till the time the patient has the next recurrence, which in stage four is a definite yes, it is going to come again. Now the next step you take, and you offer the next targeted therapy, is about 2 lakh rupees an injection, because the patents are still there. We don't have biosimilars available in the market. It becomes all the more difficult, and that drug has to be taken every month for till the time the patient has a third recurrence. Vis-a-vis, if it is a hormone positive cancer, we are only changing the hormone every single time. So a lot depends on what stage, a lot depends on what kind of cancer it is. And that's why I think it's important that we talk about the cost of treatment also. And that makes breast cancer awareness and catching it early extremely important, because the earlier you catch it, the higher are your chances that you will survive the cancer, and lower is going to be the cost of treating it.
Yeah, I know I might have jumped one step because this is weighing in my mind. But nowadays we've heard that cancer is affecting even the younger people, and maybe you can you tell us about young people who are getting affected by cancer, what is the percentage in them, and so on and so forth. And what do you recommend? Is there wearing a particular type of bra which makes a difference, or is it doing your self-examination every time which makes a difference, or is it mammography which is important? Some people say mammography is not so important. It's better to get your breast self-examination, learn how to do the breast self-examination. So if you can have all these factors together, I want to ask as many questions as possible.
I think this is a very, very layered question. There are so many questions to part of it. But if there is anything that I miss out, you just remind me again, I'll talk about it. So first was young patients being diagnosed of breast cancer now. Actually, the percentage world over is almost the same. We in India are a younger population. So if you see our population pyramid, we are a younger population when we compare it to the population pyramid of a Western country like US or the UK. So this makes a lot of difference. That means the number of younger people that are available in India are much more as compared to the number of younger people available in UK or US. So if I were to say that about 20% of triple negative breast cancers are young patients. Now, the same 20% in US, same 20% in UK, and the same 20% in India are going to be different absolute numbers, because what we are multiplying it with is a larger number we're talking about. That's why we see a little more number of younger patients being diagnosed in India, because we are a younger population. Does cancer coming in young population make a difference? Yes. The younger the patient is when she gets diagnosed or he gets diagnosed with breast cancer, the poorer is going to be the outcome. So it is a well-known fact that younger patients tend to have higher grade of the tumor and higher chances of metastasis later on, and a poorer survival. So older the patient at the time of diagnosis, easier it is going to be to treat that cancer. So that is about young cancer in younger women. There is definitely a higher propensity in younger women to have triple negative breast cancer. Triple negative breast cancer is one of the three that I was listing in the previous question. Triple negative is a more aggressive kind of cancer between the three of them. So hormone receptor positive is the least aggressive one. HER2 positive, if treated with targeted therapy, is little bit more aggressive as compared to hormone receptor positive, but is less aggressive as compared to triple negative. Triple negative is one of the most aggressive kind of breast cancers. So the propensity or the percentage of triple negatives in younger population is higher. So that makes a lot of difference. Now, the next question I think you asked was, what are the risk factors, as in what kind of bra she's wearing and what is. So the risk factor currently that we see, and one of the most commonly, we divide the risk factors into something that is modifiable and something that is non-modifiable. So I'm not going to talk about the non-modifiable risk factors because we really cannot do anything about it. But modifiable risk factors, which we see currently happening in our country, which has increased the breast cancer incidence in our country, is obesity. Obesity is one of the most common and easily modifiable risk factor. When I say easily, it takes effort, yes, but it can be done. So obese woman or obese man is going to have more hormones. The inflammatory markers are going to be higher, and that is going to increase the risk of breast cancer. Not just breast cancer, there are a lot of cancers which are associated with the inflammatory markers. But yes, it does have an effect on this thing. So our younger population, in spite of being a younger population, we are this is also a known fact that we are a more obese population when it comes to certain. We're not as obese as the US or the UK, but we are not as fit as our South Asian counterparts. So we need to improve ourselves when it comes to a regular exercise that we carry out. I always advise anybody who's accompanying a breast cancer patient with me. So obviously we'll have have a lot of mothers and grandmothers who will come to the OPD who are the breast cancer patients, but will be accompanied by a granddaughter, a daughter-in-law. And I would advise them to take exercise extremely seriously, because now they have a family history. And obviously, the exercise that I tell them to do is any exercise that they like should be done at least 40 minutes a day and should be done at least 5 times in a week. That's enough and not more than that. And I think that much amount of time can be given to your health. And it is not, and it's a multi-pronged benefit the exercise going to give you. It is going to prevent cancer, it is going to prevent heart disease, it is going to prevent brain disease. So might as well do that. The other thing that you asked was the kind of clothing that it's always important that you wear a good supportive clothing. A bra that is used is a good supportive bra. There are certain there are certain articles on internet which says wired bra cause this, and that's not true. A wired bra which is not which is not constricting the breast is okay to wear. Any kind of bra is okay to wear till the time it is not constricting the breast. If it is providing good support, it's enough. You don't need anything more than that. It can be as fashionable as it has to be, it can be as simple as it has to be, but the purpose of wearing a bra would be to give support and not constrict the breast, which is most important. And that decreases the chances. I mean, that whatever fear that a bra puts into a mind, that can be decreased by doing that. I think I answered all of them. If there's anything I missed out, please let me know. You're muted, madam.
There was one more question which was related to hereditary and other things. But along with that, I'll put two more. One is about triple negative. How frequently is triple negative detected in our women in India? What is the percentage? And the rural and urban divide.
Okay.
What is it like? Is it too much in the urban areas or too little in the rural areas, or how it is? And has the baseline remained the same? I mean, we know that breast cancer is increasing all over the world in a very big way. It's become like one of the major things. Is it just in India, or is it controlled in India? What is your impression?
So let me first question first, which is triple negative. So the percentages of cancer all over the world are almost the same. When I talk about ERPR positive cancer, 60% of our patients are ERPR positive, 20% are triple negative, and 10% are HER2 positive cancers. That's the, broadly putting, this is what the percentage is going to be in any population, whether it's India, whether it's America, whether it is. But because we are younger, we see more triple negatives and we see a little more of aggressive cancers that I've already answered before. Now talking about urban and rural divide, which I think is one of the most important, one of the most important pointers towards how our lifestyle is changing cancer. So there is a definite increase in the urban areas. I will put it in numbers. So if I were to look at UK, and if I were to look at India, and in India, we will look at the Mumbai Cancer Registry. We will compare it to a village cancer registry, which is known as Barshi. Barshi is one of the villages which has been included as a cohort for breast study. And that is a rural registry, and it has a semi-urban registry along with it. We are talking about a rural registry right now. So I will tell you the numbers and you will understand what I'm saying. So if I were to talk about 1,000 women, about 80 women in US will get breast cancer. In Mumbai urban, or Barshi urban would be about 30 to 32 women per 1,000 will have breast cancer. When we talk about rural, it is between 6 and 9. So 6 to 9 women. So that's the difference between rural, urban, and a properly westernized society. We were earlier a little better on numbers on the urban side also, because our lifestyle was still more towards how it is practiced in the rural areas. But now with the westernization, we have taken all the bad habits from them and kept it with us. We are leading stressful lives. We are running between job and home and not really resting. Our children are smoking more. Our children are consuming alcohol more. They are not doing proper exercise. They are not doing regular exercises, and that is increasing the chances of getting cancer. So most of the preventable causes of cancer are not being taken care of.
Okay, so are you saying that the numbers have increased in India also along with US?
There is an increase in number, especially in the urban population, but increase in number is not as substantial as it is in the US and UK. But as we are westernizing, the numbers are further increasing.
Okay, so the one more question that I'd asked that time was about mammography and breast examination.
Yes, that I think is an important thing. So mammography is a screening modality which is practiced in US and UK as a population screening method. So that population screening method would mean that I would, if I was the US government, I would invite all the women of United States to come in and get a mammogram done once every year or once every 2 years. All the women beyond certain age. Now, why beyond certain age? Because mammography can find out cancers in women of a certain age group. USPTF, the US Preventive Task Force, suggests that you can do mammograms after the age of 50 and do it till the ages of 74. In that age group, there is a benefit, a definite benefit that a mammogram can provide in terms of mortality, because when you're doing screening, what you're looking at is mortality. So it actually saves lives in that age group only. Earlier than that, the breast is dense, the overdiagnosis because of mammogram is more, and the benefits offered by mammogram are less. Same country, a different organization, which is American Society of Radiologists, suggests that you should start at 45. The the NHS, the National Health Scheme of London, of UK, gives a different age group. So to be able to decide whether to do screening, mammographic based screening in India, there are two problems there. One, the volume that we will have to mammogram or we'll have to screen to be able to find that amount of cancer. Second, are our health systems so are we geared enough to pick up that much amount of cancer and to be able to treat it in time? That also is a problem with us right now. So I think in India, the key at younger age would be to spread awareness, to tell everyone how to do a self-breast examination. Self-breast examination in the previous studies, in the studies which are published, have shown that it does not it does not amount to improved survival, but it definitely amounts to a better understanding of breast by a woman. So if that happens, obviously the woman is going to be able to pick up cancer earlier and come for examination. So what I tell my patients in the clinic, if someone asks me that whether would you advise mammogram to me or someone who's had a breast complaint. So what we do here in India right now is called as opportunistic screening. When the patient has come to you, has some complaints related to the breast, I can ask for a mammogram, which tells me if the breast is healthy or not. Can we do screening based, population based screening in India? As of now, not with mammography, but with clinical breast examination is possible. And if I were to do a population-based screening in India with mammography, I would do it for the ages between 50 to 74, as it is suggested in the USPTF.
That gives a lot of insight because, young college girls very anxious to get the mammography because they've heard about it or the parents are talking about it. Or sometimes it's even fashionable to go in for a mammography and say that, I went for the test. I know cost is a huge factor, and I also know that most of our population is not insured. So, do you have conversations with insurance companies about these things, or that's not your end?
No, very regularly, actually. What happens is a lot of insurance companies, but these conversations are not on the basis of population-based screening. But these conversations happen when, breast cancer treatment is a very evolving branch. Every single day, there'll be a new paper, it'll be a new drug launched in the market, and that would have not been seen by the insurance company and not included in their protocols, and hence they will not pay for it. So what the regular conversation that we have is patient to patient basis, where we have to explain why this drug is being offered, and when it is so expensive, why it is being given to this patient, what is the benefit. And at times we end up getting a little frustrated also when we are talking to the insurance companies that, why can't you just understand that this is of some benefit? And the person who is responding from that side, it's obviously there is no you're not talking to someone, it's emails which are going through and fro to make sure that the patient benefits from the insurance that is when the patient benefits. But yes, on screening, I don't think any insurance company anywhere in the world covers it, except for government, when the government pays for it, like in NHS, or when the government pays it, like in the United States. And I think we have to have a much bigger budget for our healthcare in India before we start screening for, especially mammographic-based screening, if you were to offer in our population.
Thank you, Dr. Garvit. So now we move on to something different. We keep hearing these days about men getting breast cancer. And normally, I don't know whether because the percentage is small or because men are shy to talk about it, but there's always a hush hush. But at the same time, we keep reading articles, we keep hearing that there are going to be webinars about breast cancer for men. What is your take on that?
So, like you mentioned, the percentage is extremely small. There are two problems with it, and I think the one is anything that has a smaller percentage, anything that is a rare disease, it tends to become an orphan disease. No one does research on it. There is no funding to it. There is no, no new drugs that come out for that particular disease. So the percentage, to put it in numbers, the percentage is 1% in any population. So if I were to see 100 patients in my OPD of breast cancer, one of them is going to be male. And yes, it is seen in men, and it is staged as it is staged in women, the same way. It is treated as it is treated in women, exactly the same way. The surgery, the chemotherapy, the hormone therapy, the targeted therapy, and radiotherapy are exactly the same how it would be. Obviously, the when it comes about hormone positive tumors, the hormonal manipulation changes a little bit, because there you're trying to manipulate one different hormone, and here you're trying to manipulate the different hormone. But technically, the hormones are the same, but manipulation changes a little bit. That's all that treatment changes. But about 3 years back, in one of the leading journals, which we all us oncologists refer to, is JAMA Oncology. This is Journal of American Medical Association, and that published a data, and it was a huge database of about 8,000 to 9,000 male breast cancers, and it was obviously a collated data from a good number of countries and good number of clinics. It showed that when compared age to age and stage to stage, men tend to do worse as compared to women when it comes to breast cancer, even if it is offered, even if they're offered as whatever, equal treatment. Now, obviously, there's definitely men don't do well. That is proven when it comes to breast cancer. Now, the next bit was, men being shy of this thing. So there was, like, articles that you read. I had also written one a couple of years back for one newspaper, where I had mentioned, and I think this is what we see regularly. They don't come out with it because they think it's a disease related to women. In the urban areas also, in very well-educated men also, when they talk about lumps in the breast, I mean, it's very difficult for a man to understand that man also has breast. They want to call it chest, but whatever. It's an organ which has the same anatomy as compared to a woman, except for the size and the function. It changes a little bit, but otherwise it's the same modified sweat gland which has become a breast. They think it's a woman's disease, and that's why they don't come out with it that easily. There is definitely a lack of awareness which causes the problem. In the rural areas, there is some amount of ridicule involved with and social stigma involved associated with breast cancer, the diagnosis of breast cancer, and that also decreases the they don't report it that early. And later they report, the poorer the survival becomes and poorer are the results.
So even in the men, early stage is better cured than.
Absolutely. So the comparison is the same, although in general men tend to do worse, but earlier you catch it, the better the survival.
So before we move on to something, doctor, one more question. When younger girls are getting breast cancer and then subsequently they get married by God's grace, and they can have children, or do you suggest that they should get their ovums, etc. bank? What is the system? That's number one question. The number two question is that can they breastfeed? Because I think these are the two things which matter a lot for women.
Yes, everybody asks. Yes, true. So when we're talking about younger women, first we're going to talk about fertility, and then we will talk about breastfeeding. So by fertility, I mean whether can they get pregnant later on or not. So when there are a few extra points that you need to think about when you're treating a patient, young patient with breast cancer. What is the definition of young patient with breast cancer? Anyone who's diagnosed with cancer before the age of 40 years of age is called as patient with young breast cancer or young patient with breast cancer. Now, in all these women, we add two additional steps to our counseling. When we're talking about a breast cancer patient, we're talking about treatment offered, diagnosis, breaking bad news, what is going to be the journey like, and everything, and so on and so forth. But when I'm talking to a young woman, I'm talking two more things. One is fertility preservation, because the treatment that we offer, uh, the cancer directed treatment that we offer, it decreases the fertility of the woman. By that, what I mean is, so how chemotherapy works, especially the chemotherapeutic agents, how it works is that it kills all the actively multiplying cells in the body. Most actively multiplying cell being the cancer cell in the patient's body. The other cells which the patient loses is hair, is oral mucosa, is lining of the stomach. Similarly, ovaries are also actively multiplying at all times. That's why chemotherapy, when it is given, it decreases the amount of eggs which are there, and it also decreases the quality of the eggs which are there in the ovary. So obviously, that decreases the fertility later on. They get destroyed, and the chances of fertility or having a successful pregnancy is less post chemotherapy. Do we do anything to preserve it? Yes, that is where fertility preservation comes. What we offer, what has some evidence, is embryo preservation. So if the lady who's come to the clinic is married, uh, and legally married, which is what the Indian law says, they can preserve their embryos, where the husband's sperm is taken and the wife's ova are taken, and they're made into embryos, and they're frozen. Okay, they're cryopreserved, and they remain with the lab, and when the pregnancy is planned, they are implanted back into the uterus and they grow as children. Now, this has the highest success rate. The next would be oocyte preservation. If the patient does not have a legally married partner, then you preserve only the oocytes, and those are preserved, and they can be used again to fertilize with the sperm and then used again. You can, if oocytes are not available, then only ovarian tissue is taken and preserved. At times, time is of essence, and the patient presents with higher grade. At that time is not in the mental capacity to understand what we're talking about when we're speaking about fertility preservation, because at that time they're worried more about to deal with cancer first and fertility later, that kind of attitude. Then we start with something known as LHRHA antagonist, which what it does is it suppresses the ovaries. By suppressing the ovaries, the activity in the ovary decreases, and hence the effect of chemotherapy on the ovary decreases, and hence the chances of pregnancy improve. But it's in the same order: best with embryo, second with oocyte, third with ovarian tissue, and fourth with LHRHA. And the fifth option that we give them is, if everything's okay, the best would be, if they can and if their family is allowed, to adopt a child. And, we have enough number in India. They can legally adopt a child, although the process is very tedious. It's difficult, but yes, I have a couple who've adopted children after having breast cancer. About breastfeeding, there is no harm in breastfeeding after the patient is completely treated. She can breastfeed without any problem. It does not increases the chances of cancer in the child. It does not increase the for any other cancer for that matter. The other discussion that we have with the young breast cancer patient is the genetic counseling. A younger breast cancer patient is more likely to have cancer because of what we call as germline mutation or familial mutations. There is change in the DNA, which is the cause of cancer, and that DNA has been, it has come down the family, and there is family history where a defective gene has crossed from generation to the generation, and that is how this particular patient has developed cancer. Now, in that case, it becomes important that they get diagnosed because of the germline mutation, because when there is a germline mutation, we have a proper treatment offered where the adjuvant therapy changes a little bit. We are able to tell them that, there is 50% chance in every pregnancy that they are going to have when they have children of getting a germline mutation in the child. So, and there are ways to prevent that germline mutation from going down. So, like I said, the embryo preservation in these people, we tell them whenever they are planning to have pregnancy, they can have an IVF, which is in vitro fertilization, which is what is the technical name for a test tube baby, where again the sperm and ova are taken, made into embryos, and multiple embryos are made. It's not just one sperm and one ova. Multiple embryos are made, and each of these embryos before implantation can be tested for a particular germline mutation which the mother had, and the embryos which have it are not implanted, and when embryos which do not have it, they are implanted. Now, science has gone so far to prevent genetic mutations from going down into the germline. Obviously, all of it comes as a cost, at a cost, and not everyone can afford it.
Dr. Gadgil, the amount of information that you have given about these things, I don't think has ever been discussed before. Before we move on to something else, one more thing is, you mentioned that the embryo can be implanted after some time. So what is the timeline that you take into consideration before you implant the embryo? And the second is that, how safe it is to have sexual activity, because nobody seems to be talking about sex to the patient, so they are always scared about it. So what is your opinion?
So I think that's a very, very important important question, and it's difficult that people don't talk about sexual intimacy or physical intimacy when they're talking about breast cancer treatment or cancer treatment for that matter. All of us are trained to answer this question. There are chapters available in our books which train us how to answer this question, but it's a topic which has a lot of stigma, and then hence the discussion does not happen. But now the hospitals are stepping up to it, the clinics are stepping up to it, the breast cancer units are stepping up to it, and they're talking about what they call it is an intimacy clinic. So a relationship and intimacy clinic, where we talk about the safety of physical intimacy while the treatment is on, even when the treatment is on. So when the patient is undergoing chemotherapy, there are certain days when we tell them to avoid any sort of infection. I'm talking about infection food wise, because at that time the immunity of the person is down. On all other days, it's normal. It's normal life as is. So should be sexual activity, as normal as it should be. So there is no harm in having sexual activity while the treatment is on, provided that we tell them to have a barrier method of contraception, because we do not want to complicate treatment with a pregnancy at that time. Although having a pregnancy while the treatment is on is very difficult, but we tell them to have adequate contraception, and most of the time the contraception we advise is barrier contraception, which in common parlance is called condoms. But we don't give them oral contraceptive pills, because that is hormonal, that manipulates the hormones, and that makes the treatment difficult. So we don't advise OCPs for sexual activity, but we advise condoms or any barrier method or other methods, physical methods which are there. Now, I think that was one question. What was the other question? I'm sorry, I forgot that.
about the ovum, what time?
So the timeline of pregnancy. So if the embryo is preserved or the oocyte is preserved, the timeline of pregnancy generally what we say is that you should wait out at least 2 years for the disease to show. So if the patient has come in a stage 3 cancer, say, I would not want a patient to have a child and then she develops a stage 4 cancer where she is not going to survive. So then we advise that wait for at least 2 years before you decide to have a pregnancy. That 2 years is a time period actually taken by us to see how the disease pans out. If the disease is an indolent one, if it's not going to be a very aggressive disease, then we allow them to have children after 2 years. That is in triple negative breast cancers, because triple negative do not have any hormonal manipulation involved there. In ERPR positive patients, the trick becomes a little difficult, because we are already giving drugs which manipulate the hormones, and pregnancy, as you know, involves a lot of hormones there also. At that time, having a pregnancy when these drugs are being given is not advised. In fact, some of these drugs cause congenital abnormalities in children, are known to cause congenital abnormalities in children. So we strictly tell them not to get pregnant and use barrier contraception at the time of this, when this maintenance phase is going on. So in a ERPR positive cancer, which is actually a lesser aggressive cancer, we tell them not to have pregnancy till at least 5 years, because till 5 years, the treatment should go on, and then take a break from hormones and then have a plan a pregnancy. Now, it becomes very tricky. Say if a lady was diagnosed at 35 of breast cancer, and I have given her chemotherapy, I have given her 5 years of hormone therapy, the chemotherapy has already taken a toll on the ovary, and I have already given her another 5 years of hormone therapy. So basically, when she comes up for, she comes back after 5 years, she's finished her treatment, and now she asks that, is it possible to, if she can go ahead and have a pregnancy? Now, at that age, at 40, in a normal Indian woman, it is difficult to conceive. And now we are talking about assisted reproduction in a woman who's gone through cancer treatment, where ovaries are not functioning properly. That is another difficult thing to achieve. So the timing has to be according to what the stage of the disease was, what the kind of the disease is, and that's why it is called personalized medicine, because you have to personalize it according to the person's, how the patient is going to perceive it. Some of them want to take the risk and stop at 2 years, even the hormonal therapy stopped at 2 years, and go in for a pregnancy, because that pregnancy is so important for them. While some of them come with a broader and an open mindset and said, we don't want a child. If we want a child, we will go ahead and adopt one, but I don't want to risk my life for getting a child. So, it's a basket full of different kind of people, each of them, each one to themselves, and they have their own personalities. And our job is to see what personality and what they want, and provide them a modified solution according to their needs and their time.
Dr. Garvin, there are two questions which I would like you to answer before we move on to what I have in mind. These are from the Facebook page, and one is the stress is said to be one of the factors which can be the cause of cancer, and there is a forced menopause, which is a part of some targeted therapy. Does this affect fertility?
Yes. So I think I have already answered the second one in quite detailed this thing. Forced menopause is because when we're giving chemotherapy, that causes menopause. And before, in younger women, we sometimes cause this menopause. The LHRHA injection that we were talking about, it actually suppresses the ovary, and that suppression of the ovaries decreases the effect of chemotherapy on the ovary, and that is to actually prevent fertility or preserve fertility. It also has an additional effect on hormone positive cancers, because when you decrease the amount of hormones in the body, the cancer growth decreases. So that's, there are two benefits with that. So that forced menopause, yes, it affects fertility. If it is without ovarian suppression, the chances of effect on fertility is almost permanent. But if it is with ovarian suppression, the chances of fertility coming back are higher. I hope I answered that question. And about stress being a factor for cause of cancer, yes, it is. Mental stress is known to cause decrease in certain enzymes and hormones in the body, which increases the inflammatory pathway, which increases the chances of getting cancer, any cancer for that matter. So yes, how do you decrease it? Exercise regularly. It increases endorphins in the body. Have a healthy lifestyle. It's the most cliched statement of the universe, but it's most true also. I know it's very difficult. It's not possible in today's day and age to live a stress-free life. But I think we should take more breaks and have a little more time to ourselves, which will decrease the stress.
Yeah, I know, especially COVID has created a lot of problems. And have you seen a number increase after COVID? Because I think almost everybody's stressed either about COVID or the treatment or something or the other related to it.
I have definitely seen an increase in the number of women who have come to me for cancer treatment where they're taking some or the other drug for mental stress. Some of them have come with the diagnosis of clinical depression and they're on treatment for it. And we have to obviously change our treatment according to what drugs these patients are taking. Uh, has it increased the stage of breast cancer? Yes, at the time when when the patients had presented immediately after the lockdown, there was a certain increase in the stage because they had not come out in time. But now I think it's the same. We've reached the same stage once the travel has opened up and people are freely traveling to different cities and having a lot of uh, you know COVID in one way has improved communication also. So earlier, what it used to be, if a woman was coming to me from, say, Dubai or West Bengal or Bangladesh, nowadays they just do the test there and have a teleconsult and say that we are okay. So that is one positive effect of COVID. We have learned to communicate better. But yes, it has increased the amount of stress. It has increased the number of patients that I see with clinical depression when they come for cancer treatment. It had increased the stage at presentation initially, but I think that has leveled up now.
So, Dr. Garvit, you were working in a public hospital and now you're moved into a private hospital.
Yes.
And the numbers must be, much less than what you
Yes.
saw in
Yeah.
general hospital. So, what are the differences that you feel as a doctor that when you in your practice as a general as a doctor in a general hospital and in the private hospital?
So, there are two. I think this is a question I've answered many times, and I've answered it to friends, family who saw me change this practice from a public sector hospital, which had patients climbing onto each other to meet you, and to reach out to a private center where you are waiting for the patient to come in. So that's the biggest difference that you see. Uh, but yes, in terms of presentation, stage at presentation, it changes. I see a lot more screen detected cancers now. I see more women who are more breast aware, who are regularly examining themselves, who come at an earlier stage. So in fact, just last week, I have finished my 1 year in private practice, and I was just auditing my data, and I found that about 55 to 60% of my patients were early breast cancer, which almost reaches the level of early breast cancer that you would see in the West. While I was seeing the same number of locally advanced cancers when I was in a public sector hospital, which is Tata Memorial. And I was there for about good 10 years, and now this is just 1 year here. So I have seen a good switch. It's a happier switch in terms of the stage of cancer that I'm seeing now. Obviously, in a private setup, the population that reaches you has healthcare more easily available to them, and that's why they are able to pick it up early and they come in time. When vis-a-vis when you meet a patient from public sector, and obviously my heart still goes out for them and it will always will, is they have to fight a lot of battles with before they reach you. They the that there there are hurdles at every level. There is hurdle at diagnosis. Forget about diagnosis. There is hurdle at awareness. A lot of women will not know when they, especially when they're coming from the rural setup. Let me not put it rural, urban also. Let me not put it as educated, uneducated also, because I've seen them all. they come when they're coming from far-fetched areas. They come with this thing that since there has been no pain in my breast, there is no cancer, and that's why they took some time. That's the level of awareness we have a mistake in. The most common symptom, as you all know, in breast cancer is a painless lump. So people don't realize that, and because it is painless, they don't want to report it. Now that from that level where awareness was problem, then the next problem comes. Uh, the lady who's obviously, I'm talking about breast cancer, so it's more commonly seen in women, and that's why I keep referring to them as ladies, because those are the most common patient background, patient base that I have. So ladies, they will say that, I have to take care of my child. My child is going to school. There are exams coming up, and my husband has to go for work. How can I take out time for my health? That is the second hurdle. The third hurdle is the caregiver has to take leave from work to reach out to a public sector hospital, and that caregiver might just be a daily wage worker, where every day of work lost is every day of difficulty, increase in difficulty in feeding the rest of the family. So that is the difference that you see. When you're in a public sector hospital, you're also seeing patients who are worried about where the next meal is coming from. Vis-a-vis, you're seeing patients where they have enough to feed probably few generations if they were not to work for some time. But that apart, obviously, awareness is better. The patient, that's why probably we see a lot of patients who come in earlier stages of cancer are offered better, treatment, which is lesser in intensity. They're able to afford higher, or let me not say higher, but newer available molecules, which may come at a cost, but they're able to afford it, and hence may have a better outcome as compared to public sector hospitals.
So, Dr. Gasvik, now you may be getting enough time to talk about the side effects of the treatment. I don't know whether you get or you don't get about the side effects of the treatment that you are going to offer to the patient. But do you get enough time to also explain to them about the late side effects? Because all the side effects don't happen when the treatment is going on. Many come in at a much later stage, and the patient is not aware of it because the doctor probably has or spoken about it or something like that. So, what is your thinking and about the whole thing?
So I do make it a point to talk to them about all the side effects possible. But these are not something that a patient is going to understand. Say, even if it is a private sector hospital that I'm working in right now, I have a good number of patients, and makes if I were to have discussion about breaking bad news first, and then stage of the treatment, and then side effects of the cause of the treatment, cost of the treatment, and side effects. Even if I have a session of about 1.5 hours for the first time with the patient, and even if I have told them everything that there is to tell, it's very difficult for a person to understand in that one go, where the emotional turmoil which is happening within them is already at such peak, where we are talking about starting treatment tomorrow. We are talking about side effects of it, and we're talking about fertility preservation. We're talking about genetic this thing. It's difficult for them to get into, to understand that much in one go, which is where patient organization like yourself or WeCare or other, which I'm enormously thankful to, they come into play, where they help the patient, handhold them during this journey, which is where you guys are able to help us physicians or doctors out. Because that is one thing, no matter how many times I do it in my office, no matter how much time I'm able to spend with the patient, I will not be the best guide. Most of these patient organizations have volunteers who have gone through this journey already, and it is these volunteers are who end up becoming the best guides, because they have gone through this journey. They are able to handhold the new patient through this journey easily. They are able to give them exactly how it is going to feel, exactly what all problems to expect on a personal level, on an emotional level, on a physical level, and exactly how to overcome these, and which is where patient organization like yourself or support groups or where they come into play. And yes, I am able to tell them in the first go. I in fact give out leaflets, I give them reading materials, I give them, and which are available in multiple languages. Some of them are provided by your organization only, where we tell them to read about all this. And but a lot of that, you will see I give them leaflets, and next time when they have come for an OPD visit, they will take out the same file and give it to me, and I will see these leaflets are lying inside the file unread. So a talking where a physical, the actual communication happens between the patient and you has an effect. But I think what has a better effect is when there is a hand holding by a person who's already gone through the journey.
Thank you very much, Dr. Garvit, for saying that, because that would mean that you would remember to encourage patients to connect to the patient organization. And I think, when a doctor says that meet this organization or meet this person, or it's important for you to go to a patient support meeting or something, it makes a lot of sense, because otherwise, sometimes the impression that a patient has is these ladies are only here for just being there. They really don't know much, but the doctor would know the best. But if the doctor says that the patient organizations are important, I think it will really add credit to the work that the organizations are doing. And that is one request I think all the organizations have of the doctors, to remember us for that 1 minute to tell the patient to connect with us and be with us. And so, Doctor, I'm sure you must be doing it, and I'm sure you now do it even more consciously. One thing which leads to the end of the treatment, we've started created awareness, we've done the treatment, we've talked about the side effects of the treatment, but now comes the palliative care or supportive care, which is extremely important. First of all, why do we call it palliative care, and why not just supportive care? Because today's palliative World Palliative Day, I think, and this question is even more meaningful, because we don't want people to feel that it's the end of their journey. And one thing I feel that why don't we talk about palliative care from the beginning? Because when we say palliative care, when all of the treatments have failed, and the patient feels that the treatment has now failed, so I'm being put on to something which is bad, because that itself is bad for the patient. But if we talk about it from the beginning and we don't call it palliative care but call it supportive care, will it make a difference to the psyche of the patient? And what's the difference? What would you say?
I think, madam, you've hit the nail on the head in the first statement itself. The name itself is wrong. So let me, for all those who are listening to it right now, there's an intent of treatment that we decide when we've seen all the reports. On the first meeting, when I've done a biopsy and send the patient home, and the patient comes back for the first discussion after diagnosis, the first job that I have to do is to decide what is going to be the intent of treatment. Is it going to be curative? Which means that, am I going to be able to get rid of this cancer completely, at least for once, with giving patients a certain amount of risk of recurrence? Or am I going to offer the patient a palliative intent treatment, which would mean that I'm not going to be able to cure it, but I'm going to be able to give drugs or offer therapies which are going to make the patient's life easier, or even in today's world, control it. So that is the intent of treatment we're talking about. When it comes to care, naming it palliative care itself is wrong. And it has to start at day one. Because the moment you say palliative, it automatically, it comes into the head of the patient. It is not curative, which is a negative word, which is not how you should start treatment, even if it is stage 4. Because today, stage 4 cancer of stage 4, especially breast cancer of stage 4, there's enough number of years left in life. Not for everyone. Some of them have smaller amount of duration of life left, but for most of them have good number of years left. So if you start the treatment on a negative word, it's going to be a negative all throughout. Calling it supportive care and starting it on day one, even for early breast cancer, I think is one of the most essential steps that now the world of medicine is realizing. And I think the Western world has already moved on to it, where a supportive care specialist sits in the MDTs or the multidisciplinary team from the very beginning. And I think that can be done. I think our problem that we face is that we do not have so many supportive care therapists who are available, who can sit in MDTs from the very beginning, and that's why we are only playing catch up when it comes to palliative or supportive care. So it is offered once we reach that stage. But yes, it is much better to start from the very beginning. And the supportive care which is going to be offered is offered different kind when it comes to, like any therapy, whether I'm going to offer chemotherapy or surgery or radiotherapy, is going to be based on the stage of the treatment, stage of the disease that the patient has. Similarly, supportive care is also going to change according to what the stage of the treatment has. And supportive care should not be limited only to end of life care, is which is now, it's currently considered as. But that's a wrong statement. It's not correct, and we should start supportive care for even patients with stage 1 treatment and start it from day one.
Yeah, why I was asking you this, Dr. Garvin, because what happens is when the cost certificate is given to the patient and it says palliative care or palliative chemotherapy or palliative radiation, and the patient goes to a trust or some organization to take money for it. The moment the organization is not, informed so well about the palliative care, as they understand that palliative care is, there's really no active treatment that is being done, and so palliative care. So they restrict the giving of their financial help to the patient. And they're almost like, I don't know whether it's put in words, but it's almost said that, we'll see whether we can do something or not. And that again adds to the trauma that the patient is facing. So that is why, I feel palliative care adds to the trauma more than anything else. So if it can be taken care of, especially our patients who need financial support, I think it will make a lot of difference.
Madam, I think there is a little bit of a issue from our end also in that. When we call palliative chemotherapy or palliative radiotherapy, there is some amount of medical legal issues that we are trying to address when we call it that. It's necessary. If we don't, technically on paper, we are not declaring what the stage of the patient is, and which is wrong on our part to not do. I understand that when a letter for request for support goes out to organizations for help, financial help for these patients, they tend to filter out the palliative ones and keep only the radical treatment ones with them. And because technically these patients are already stage 4 and the treatment is not going to benefit, which is wrong. Treatment is going to benefit and they're going to have a better life and hence should be provided for. But changing the name of the treatment at the time has a medical legal issue, and that's why hence I think it is difficult for us to change those statements there. But I think we need to change our mentality as support groups also. So we have to change our mentality as organizations also, that palliative care always does not mean that it is end of life care. These are two different things. Yes, we need to provide those, even palliative radiation is going to be as important as radical treatment when it comes to giving a good quality of life, and it is necessary, and obviously it comes at a cost which is not which is ultimately going to be borne by the patient, whether the patient gets it from somewhere, from a public funding or from an organization. They have to get it. But there are certain organizations now who have change their lookout towards this. They come back, communicate with us that what are you looking at? Are we looking at life which is of certain amount, certain quality? Then we will definitely support, even if it is stage 4. But certain organizations have in their mandate have clearly said that we will support only patients who can achieve cure, and we will not support patients who cannot achieve cure. And I think in a way, they're also not wrong, because if you have only so much funds to distribute, you would want to give funds to the patient who's going to make it as in have a complete cure, while you would not want to give those funds. So if I had 10 lakhs and those 10 lakhs are going to be used by a certain patient, I would rather give it to two of those patients who require only 5 lakhs and are going to achieve cure. Vis-a-vis, I give those 10 lakhs to one patient whom I know is not going to survive beyond 1 year. At least I'm giving life to two patients, and I'm not supporting the patient who is not going to make it. But I think we need to change that a little bit, and that will come once the government also chips in their bit for palliative care or end of life care or supportive care.
Thank you, Dr. Garvit. I know we've gone a little beyond schedule, but I think a very different perspective on breast cancer has been brought about by you. And I hope the number of people who get cured rises and people understand their own responsibility. And for us, again, one challenge that we face is that, if we have to support a patient who is in a government hospital or in a private hospital, then the choice becomes even more difficult, because to support somebody who's gone into a private hospital is difficult because of the increased.
Because they've chosen to pay. I can understand that. Yes.
Yeah. So, but all of us have our own
Yes.
challenges and obstacles and all that. But I'm sure today's talk was one of the most different one, and I'm sure everybody will benefit from it. And thanks a lot for giving so much of your time, Dr. Garvit, and thank you very much.
Thank you very much, madam, and thank you for having me here. Before I close, and I wanted to make one last statement. I think you'll allow me just 1 minute. That is that, there was this thing that someone had asked me, how do the patient organization raise awareness? And I think we need to engage ourselves, and that is one point which is very dear to my heart, and we need to engage ourselves more. If we want to see a better cure rate, like you said, and want to see a better survival, we need to make everybody aware on how to pick up breast cancer. And the most common symptom of breast cancer is a painless lump. If you have it, please get it shown. Maybe if God forbids, if it turns out to be cancer, if it's early stage, we'll be able to save your life, and you will be able to get away with it and get back to your normal life very, very fast without many ablative therapies, and you'll be back to normal. Thank you.
Thank you very much, Dr. Garvit. We're very happy for your time and very happy that you are associated with us. Thanks a lot once again.
Thank you very much, ma'am, and thank you very much for your organization, whom we regularly seek help from whenever we see a patient which needs help. And I think it's very important, like you said, we will bring in all our going to say that
the time, Dr. Garvit. There's a lot of talk about the new thing which has come up at ESMO about reducing the cost of the treatment during surgery and all that. Would you like to talk in one sentence or two sentences about that? Because there's so many newspaper articles, so many WhatsApp messages going around.
Sorry?
At ESMO, it was presented that if you were to give them some sort of anesthesia, it would cut
local
down
anesthesia. So that one statement, I think it's important to make because of the amount of hype that there is around that topic.
Yeah.
So that study was, we were a part of it, and it was in Tata Memorial Hospital. We gave lignocaine or lidocaine. I was a fellow, I am not one of the investigators in that study, but I've seen it happen, and we've done it as a team at that time. What we were giving, for the study, what we were giving is local anesthesia, the simple local anesthesia drugs, which is infiltrated around the tumor, and it decreases the cancer from going out while the surgery is going on. It decreases the metastasis and improves survival. Yes, it's a successful study, but it is limited to only subset of patients where the tumor is less than 5 centimeters and it has not spread to an axilla already, for axilla negative patients. So very early breast cancer, where we are able to give these patients benefit of local anesthesia around the tumor. And if you get a patient like that, for all the doctors, we must use lignocaine, and the dosages, what it has to be used in and how it is to be infiltrated, these are available in the same paper which has been, or the abstract which was published in the conference.
Thank you very much. I'm sorry I added on, but this was going on in it had slipped out of my conversation. Thank you, Dr.
Thank
Galvin. We'll take you now.
Thank you. Thank you.